Good afternoon, everyone. Thank you. For those who don't know me, I'm Anathea Powell. I'm a colorectal surgical oncologist at Dignity Health Cancer Institute here in Phoenix. And it was my honor to start my career as a general surgeon at Phoenix Indian Medical Center, which is where I initially met Captain Weahkee, as we referred to him then. Captain Admiral, I'm going to probably do that many times, was born in the Shiprock Public Health Service Hospital on the Navajo Reservation and grew up as a direct service user of the Indian Health Service. Michael began his professional health career in the United States Air Force as a military public health specialist. After completing his Bachelor of Science degree in healthcare management from Southern Illinois University, Carbondale, he left the Air Force to pursue advanced hospital administration training, receiving both his Master of Health Services Administration and Master of Business Administration degrees from Arizona State University in Tempe. If you know him at all, go Arizona State, not any other institution in Arizona. He then, as we all knew he would, he was taken to Washington. He then served from June 2017 to April 2020 as the Principal Deputy Director of the Indian Health Service prior to being nominated by President Donald Trump and confirmed by the Senate on April 21st, 2020 as the 10th Director of the Indian Health Service. He served in that role for 2 years about, before the change of administration brought him back to Phoenix, and he is now the Deputy Area Director here, the Phoenix area for the Indian Health Service. On a personal note, I was the medical staff president, and that's how we met. It was my privilege to work with him, as he had very nuanced, non-dogmatic thinking that I really appreciated. In resource-constrained environments, surgery is often considered a luxury. He never felt that way, which is also the position of the World Health Organization and Paul Farmer before he died. And it was exciting to work with someone who was able to understand the bigger picture and also have role clarity about what his role was. And that really taught me a lot about how to work both within the Indian Health Service and outside of it. I really thought of him as someone who was a disruptor, but also built consensus, which I think is very, very unique. And I think why most of us, if not all of us who have worked for him, would work for him again in a heartbeat. So with that, Admiral Weahkee.
Well, thank you, Dr. Powell. It's a pleasure to see you again and to be here at Creighton. My first time here at the Phoenix campus. So appreciate the invitation to come and present a little bit about the Indian Health Service for you here today. I always like to start these presentations with an overview of the Indian Health Service mission statement, which is meant to be a very broad umbrella and holistic in nature. It's to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. That as you think about a whole person, that mind, body, spirit concept, as well as the incorporation of both social and environmental factors within the community, are all encompassed under this broad mission statement. Start with a little bit of history of the Indian Health Service. It was formally established by Congress in the year 1955, and the provision of health services to members of federally recognized Indian tribes grew out of that special government-to-government relationship that exists between the U.S. federal government and the individual independent sovereign nations across our country. We can trace the history of the agency back to the creation of our nation, when U.S. Army doctors and providers would provide healthcare services to the Indians living right outside the forts, mainly as a means to mitigate the spread of disease to the soldiers that are serving in those forts. And over time, the responsibility for Indian healthcare moved from the War Department over to the Department of Interior, and then on to the Department of Health, Education, and Welfare, which is now referred to as the Department of Health and Human Services. The Snyder Act of 1921 and the permanent reauthorization of the Indian Healthcare Improvement Act provide specific legislative authority for Congress to appropriate funds specifically for the care and treatment of Native people. Numerous other laws and court cases and executive orders have reaffirmed these relationships over the years. I also want to underscore that the U.S. government's commitment to providing access to healthcare, as established in these treaties and laws, is the responsibility of the entire U.S. federal government, not just the Indian Health Service. We're the main embodiment of that obligation, but all across the country, every part of the federal government has the responsibility to provide healthcare treatment for American Indians and Alaska Natives. At the IHS, we provide a comprehensive healthcare delivery system and disease prevention service program for approximately 2.8 million American Indians and Alaska Natives, who are members of 574 independent sovereign tribes. And this is provided through a network of 605 hospitals, health clinics, and health stations that are located on or near Indian reservations. The IHS federal staff consists of more than 15,000 employees nationwide, including healthcare providers like physicians and nurse practitioners, advanced practice nurses, PAs, as well as dentists, nurses, pharmacists, dietitians, and optometrists. We can go on and on. We also provide a comprehensive environmental health program that includes injury prevention, safe drinking water, sewer, and solid waste sanitation services throughout Indian country. And these numbers, the 15,000, do not include the employees that work directly for tribal health programs or for our urban Indian health partners. This is a geographical representation of how we look as an agency. It varies slightly from the Department of Health and Human Services regional structure. We've got 12 area offices serving populations in both rural and urban areas across 37 states. Our patients sometimes travel great distances to get to the nearest facility, especially in states like Alaska. Some of the facilities in our health system are in large metropolitan areas like here in Phoenix. We've got urban programs in Los Angeles, Albuquerque, and Oklahoma City, and others are in some of the most rural and remote locations that you can find in our country, like in Barrow, Alaska, north of the Arctic Circle, or at the Supai Village at the bottom of the Grand Canyon. I'd like to point out that Phoenix is the regional headquarters for the tri-state area of Arizona, Nevada, and Utah, with some caveats. You see that yellow section there, Navajo Nation has its own area office because of the size of that tribe. And then down in the southern part of the state, we have a separate Tucson area office that services the Tohono O'odham and the Weahkee tribe. The main Creighton campus, which is located in Omaha, is within our Great Plains area, which is headquartered in Aberdeen, South Dakota. And that area services the states of Nebraska, North and South Dakota, and Iowa. Here's a breakdown of those 605 programs I mentioned. Some of the programs are operated directly by the Indian Health Service, the federal government, while others are operated by tribes and tribal organizations under the Indian Self-Determination and Education Assistance Act. This gives tribes the option of exercising their right of self-determination by assuming the control and management of the programs that were previously administered by the federal government. And since the law went into effect in 1992, the IHS has entered into agreements with tribes and tribal organizations to plan, conduct, and administer these programs under that act. And as we speak today, over 65% of the Indian Health Service appropriation is administered directly by tribes. The IHS also provides funding for 41 urban-centered health organizations that provide care for American Indian and Alaska Native patients living in metropolitan areas like in Baltimore, Denver, San Francisco, and as mentioned right here in Phoenix, as well as in Omaha, Nebraska, where Creighton University's main campus resides. In addition to almost $7 billion that was appropriated for the IHS in fiscal year 2023, the Appropriations Act also provided the agency with what's called advanced appropriations for the very first time. This change provides critically needed protection from budget uncertainty to the entire Indian health system, such as during times of a government shutdown or a continuing resolution. And this aligns the IHS with other federal healthcare programs like the Department of Defense and the Veterans Administration. It's also a direct result of years of advocacy from tribal and urban Indian organization leaders who've long highlighted the need for a more stable and predictable funding stream for the Indian Health Service. Advanced appropriations are necessary to help ensure continued access to critical healthcare services for American Indians and Alaska Natives. This predictable funding allows us to disperse funds more quickly to the tribes and enables our IHS tribal and urban programs to effectively and efficiently manage their budgets, coordinate care, and improve health outcomes for American Indians and Alaska Natives. Despite this recent good news from the 2023 budget, the IHS continues to face critical funding deficiencies that impact our ability to carry out our mission. The federal government spends less per patient on healthcare for American Indians and Alaska Natives through the IHS than it spends on any other federal health program. In the year 2021, the actual IHS spending per user was $4,140. And by comparison, Medicaid spent $8,908 per enrollee. The Veterans Health Administration spent $12,223 per patient. And in 2020, Medicare spent $15,763 per beneficiary. And these numbers have been adjusted to account for those American Indians and Alaska Natives that qualify for each of these other federal health programs. Next, I'd like to touch on a few of the health disparities that disproportionately impact American Indians and Alaska Natives. You've got a lot of them included here on this slide, but I just want to highlight a few. Starting with life expectancy. American Indian and Alaska Natives born today have a life expectancy that's almost 10 years less than that of the US general population. American Indian people have long experienced lower life expectancy and lower health status when compared with other Americans, both of which are linked to social determinants of health, or what many are starting to refer to as social drivers or social influencers of health. Some examples in Indian country include lack of stable housing, lack of jobs and economic opportunities, limited transportation options, limited safe water sources, limited access to healthy foods like fresh fruits and vegetables, and the list goes on and on. Lastly, American Indians and Alaska Natives continue to die at higher rates than other Americans in many different categories, including chronic liver disease and cirrhosis, diabetes, unintentional injuries, assaults and homicides, and intentional self-harm or suicide, and multiple cancer types. I'll get into more disparities specific to Arizona and Nebraska here in a bit. I did want to just touch a little bit on the impact of COVID in our American Indian communities. The disparities just mentioned were made even more evident during COVID. Our American Indian, Alaska Native communities have consistently suffered from higher COVID-19 incidents, hospitalization rates, and mortality than all other racial or ethnic groups here in the US. In fact, life expectancy dropped by 4.7 years over the past 3 years alone, due mainly to COVID, but also we've had significant increases in opioids overdoses as well. COVID-19 also revealed many health and infrastructure disparities throughout Indian country. For example, many of our tribal partners, they did not have the capacity to conduct even the most basic of public health department activities during the ongoing pandemic, and the lack of running water in many communities left them without the ability to wash their hands and to remain isolated in their homes as they had to travel out and haul water back in for their families to use. Diabetes, as mentioned, is one of the medical conditions that's been associated with increased risk of complications in COVID cases. And Native American people have had historically the highest prevalence of diabetes of any racial or ethnic group in the United States. So much so that back in 2007, Congress established the Special Diabetes Program for Indians to provide grants for diabetes treatment and prevention for IHS tribal and urban sites. While American Indian and Alaska Natives continue to experience higher rates of diabetes, this special diabetes program in Indians has actually had some significant success stories to report, and one of them is here included on the tribe. From the year 2013 to 2017, we had a drop in the prevalence rate in Native adults from 15.4 to 14.6. This was the first time ever that we'd seen a decrease in this prevalence rate. We've also seen a flattening out of diabetes in Native children. And much of the research that the National Institutes of Health has initiated has been with the tribal communities here in Arizona, with the Pima Maricopa Indian communities, Tohono O'odham, which have led to best practices across the world with things like breastfeeding, reducing or delaying the onset of diabetes in children who were breastfed for prolonged periods of time. So we're happy to be able to participate in those types of studies and have impact for the greater population. These STPI grants were expanded in 2023 with some additional funds from Congress. We moved from only 275 grantees to 302. But as I noted, there's 574 tribes across the country, so we've still not reached everybody. And then there's 41 urban Indian centers on top of that. So of course, tribes are advocating for somewhere in the neighborhood of 200 million per year, and we're at 147 million currently. Geographically, wanted to show you where Native peoples reside today. So this is from the 2020 census. We've got some significant populations here in Arizona. You see those orange sections up in the northeast corner of the state. Those are the counties where Navajo Nation, Hopi, White River, and San Carlos Apache, and the Zuni tribes all reside. So we've got significant service populations right here in our state. Now for some of that state-specific information I referenced earlier, and I've got a URL included here if people want to read more. I just want to start by extending a special thank you to Dr. Donna Polk, who's the CEO of the Nebraska Urban Indian Health Coalition there in Omaha. She graciously provided me with access to this report so that I could share some of the data with you in this presentation here today. From the executive summary of this report, American Indians in Nebraska have made some significant progress on various health issues and diseases. From the year 2006 to 2014, diabetes mortality rate decreased by 25.3 points, from 93.2 to 67.9 per 100,000. The alcohol-induced mortality rate decreased from 86.1 to 54.6 per 100,000. Unintentional and accident mortality decreased by 6.6 points, and the teen birth rate decreased from 100.2 per 1,000 births to 34.3 per 1,000 births, so significant decrease in teen births. And despite the progress that's been made, a large gap can still be seen between the American Indian and general race populations. Particularly high disparities were reported in diabetes, mental health disorders, cardiovascular disease, liver cirrhosis, and accident and injury mortality. The report is chock full of lots of stats for anybody who wants to look at that report. Approximately 21% of American Indians aged 25 and older had less than a high school education. Only 11% had a bachelor's degree. Median annual income was more than half that of the general population at about 26.8 thousand compared to 55.3 for the general pop. Unemployment rate was 4 times higher among American Indians, and they were 3 times as likely to die from diabetes, 7.5 times more likely to die of liver disease, and 5 times more likely to die of homicide than the general population. So again, I included a link to the report. If you want to read more, that's some of the general information on health status specific to American Indians living in Nebraska. We're here in the state of Arizona. I wanted to provide some more specific information. We had a report published just earlier this year from the Arizona Department of Health Services. And from that report, which was based on 2020 data, American Indian residents of Arizona rank better than average on a number of health indicators, including mortality rates for several chronic diseases, including breast cancer, lung cancer, chronic lower respiratory disease, Alzheimer's disease, malignant neoplasms, and prostate cancer. However, they ranked worse than the statewide average in 56 of the 66 health indicators included in the report. They had high mortality from alcohol-induced causes, chronic liver disease and cirrhosis, COVID-19 as mentioned earlier, septicemia, diabetes, assault, influenza, pneumonia, motor vehicle accidents, post-neonatal mortality and unintentional injuries. And they were ranked worse on measures of maternal lifestyle and health, as well as in utilization of prenatal care. So on average, American Indians here in Arizona were 14 years younger at their time of death compared to all racial ethnic groups. And again, included here is the link to that recently released report if folks would like to read more. The IHS has taken some significant steps towards becoming a trauma-informed organization that emphasizes physical, psychological, and emotional safety for both our patients and our providers, and helps survivors of trauma rebuild a sense of control and empowerment. Many of our patients have experienced trauma over their lifetimes, some as a result of failed past federal policies toward Indian people, like forced relocation to urban centers, forced assimilation into the mainstream culture, mandatory attendance at boarding schools, termination of recognition of tribes, and much, much more. The goal was to disrupt native languages, religions, and cultures, and to assimilate them into mainstream culture, which significantly impacted family support structures and the sense of community for many tribes. IHS supports efforts towards becoming a trauma-informed organization, like being patient-focused and patient-driven, recovery-oriented, integrating cultural humility, and providing trauma-informed services. The IHS even developed a trauma-informed care policy that requires all IHS employees, including contractors and volunteers, to complete training on an annual basis on the impact of trauma, including the historical trauma on American Indian and Alaska Native people. And the IHS works to implement the principles of trauma-informed care to ensure that employees understand the prevalence and the impact of trauma, and to help to facilitate healing and to avoid any re-traumatization and focus on strength and resilience. This policy also requires each facility to examine the healthcare environment and current policies and practices to incorporate trauma-informed care approaches throughout all of our programs and services. This was just recently incorporated within the last 3 to 4 years, and so a lot of this work is ongoing. You'll see different levels of incorporation depending on which site in our agency you go to, but I thought it was important to include as part of today's presentation. Some additional top challenges, in addition to the historic underfunding and the significant health disparities, IHS also faces a number of other challenges. The average age of our IHS healthcare facilities is over 42 years old, compared to the average in the healthcare sector of 9 to 10 years old. So significantly more expensive to upkeep and to maintain accreditation, certification, environment of care, patient safety. Our hospital here in Phoenix was opened in 1970, so it's 53 years old now. We are currently working with City of Phoenix, federal government, and state to negotiate land for the construction of a new facility. And we have got incremental funding coming in from Congress to take that project on. Many of our IHS and tribal healthcare facilities are at or beyond capacity. They were constructed many years ago for a population much smaller than what they're serving today. And so they're bursting at the seams, and we've had to be innovative in the way that we provide care through partnerships or bringing in temporary buildings, expanding into other local space. We're also working with a electronic health record that's more than 50 years old. what we refer to as the Resource Patient Management System, or RPMS. It's included on the Government Accountability Act's, our Government Accountability Office's top 10 list of federal legacy IT systems in need of replacement. So fortunately, we are a couple of years now into a modernization effort, working again with Congress to fund the purchase of a commercial off-the-shelf system. We're watching very closely what the DoD and VA have done with their move to the Cerner Genesis program. We've also seen a few of the other smaller systems like the Coast Guard move to Cerner. We've not yet made a selection ourselves. We know that some systems are better for large hospitals and others may be better for small ambulatory healthcare facilities. We have a lot of people at the table, including our providers, who we don't want to have to spend any more time than they have to rolling and scrolling. So a lot of input being put into that selection of our next EHR. And of course, it's going to cost a ton of money. So working with Congress to get that money together. Our average vacancy rate across the all professions is, we say provider there, but really that's all professions, is about 28%. When you get into provider types, specifically physicians, advanced practice nurses, PAs, you start getting into the 30s, 35%. Dentists also very much high vacancy rate. As an agency, we also face a lot of increased scrutiny. Most health systems are reporting to a board and maybe Joint Commission or AAAHC. We've got all of that in addition to GAO, Office of Inspector General, and Congress watching us at all times. So with that extra scrutiny comes Senate hearings, and any letter from John Q. Public could result in an inordinate amount of time to respond to. So lots of internal work to make sure that all of our programs are running effectively and efficiently. So despite the challenges we face, the IHS employs some of the most dedicated and high quality healthcare professionals around. 70% of our workforce are from our American Indian and Alaska Native communities and graduate from many of the top schools across our nation. I wouldn't be doing my job if my presentation didn't include a recruitment pitch, so here it goes. IHS and tribal and urban Indian health programs are seeking healthcare professionals who are passionate about practicing with a unique interdisciplinary team-based environment and one that embraces our mission. A career in Indian health offers clinicians an extraordinary opportunity to provide the highest level of comprehensive patient-centered care. And our clinicians recognize the unique opportunities that an Indian health career provides, and they're committed to practicing in a variety of different environments. In addition to the IHS Loan Repayment Program, the National Health Service Corps Loan Repayment Program also provides awards for clinicians that work at IHS tribal or urban Indian health programs as well. So you can do your payback time for NHSC at an IHS site. If you're graduating with medical school debt, please consider applying for our loan repayment program, which we will pay you a competitive salary while we help you pay off that debt. IHS also has an extern program that offers IHS scholarship recipients and health profession students in medicine, nursing, pharmacy, dentistry, environmental health and engineering, behavioral health, and optometry an opportunity to gain valuable clinical experience in an Indian health facility during the summer or any other non-academic periods. I also want to highlight IHS's commitment to developing the next generation of leaders. The IHS Scholarship Program will soon be accepting applications for the 2024 to 2025 academic year. And this program provides financial support in exchange for a minimum 2-year service commitment with an Indian health program in a chosen health professional discipline. The program also supports the pursuit of a meaningful career in Indian health attainable for American Indian and Alaska Native students, and eligible students are encouraged to apply by February 28th of each year. So I was talking with Dr. Vesti earlier about the exciting opportunities that exist for students internationally. We also have a lot of exciting opportunities that exist right here in the United States for those who are contemplating Peace Corps or Doctors Without Borders or World Health. You can get a good flavor of serving the underserved right here in rural America. So please give it a thought. I also want to briefly mention the role of the United States Public Health Service. The uniform that I'm wearing, the same uniform that the United States Surgeon General wears. U.S. Public Health Service for more than 225 years. Men and women have served on the front lines of our nation's public health in what we call the Commission Corps of the United States Public Health Service. At the Indian Health Service, we employ more Commission Corps officers than any other agency in the federal government. There are only about 6,000 of us nationwide, or I guess that's internationally, because we have a lot assigned to embassies as well. But for us to employ the majority here within the Indian Health Service is something notable. Currently, our Commission Corps officers are involved in healthcare delivery to underserved and vulnerable populations, like at the IHS and with the Immigration Health Services, Bureau of Prisons. We do disease control and prevention at the CDC, biomedical research at the National Institutes of Health. We do food and drug regulation and inspections with the Food and Drug Administration, mental health and drug abuse services at SAMHSA, and response efforts for natural and man-made disasters through the Assistant Secretary for Preparedness and Response. We also have FEMA attachments as well. The Commission Corps continues to fulfill its mission to protect, promote, and advance the health and safety of our nation. And the work of the U.S. Public Health Service is crucial to the IHS mission as we work together to deliver health care for American Indian and Alaska Natives across the country. I also wanted to note with a link there at the bottom that there was a recent PBS documentary developed that really tells the story and the history of the U.S. Commission Corps. And that documentary is called The Invisible Corps. So if you follow that link there, it's a 1-hour documentary, and you can watch it in its entirety through a link at that site. We're working hard to address many of the challenges throughout Indian country via partnerships. We work closely with the Veterans Health Administration through an interagency memorandum of understanding that aims to provide eligible American Indian and Alaska Native veterans with access to care closer to their homes, to promote cultural competence and quality health care, and focus on increasing care coordination, collaboration, and resource sharing between our two agencies. We're committed to working with partners like the Johns Hopkins Center for American Indian Health. They have a pretty significant presence both on Navajo Nation and on the White Mountain Apache tribal nation. Our partnership with them started more than 30 years ago when we signed our first memorandum of understanding when their Center for American Indian Health was first founded. And it's been consistently renewed by every IHS director and acting director since that time. Key areas of collaboration include expansion of workforce development for American Indians and Alaska Natives by providing educational opportunities in allied healthcare, health sciences, and for graduate and doctoral students. And they specifically focus on training for community health paraprofessionals to assist with promoting physical, behavioral, and mental health. We have a particular focus of the current MOA on designing sustainable interventions that can be administered by mid-level or community health workers, such as the Community Health Aid Program or CHAP program, and with public health nurses and community health representatives. We have many other federal and national partners. There were hundreds of them. I just picked out a selection here to point out. We have a recent collaboration with an entity called Home Base. They are a Red Sox baseball team foundation that provides services to veterans and their families on things like PTSD and traumatic brain injury. Massachusetts General, Boys and Girls Club of America, et cetera, et cetera. I very much appreciate the opportunity to come and speak with Creighton and look forward to further strengthening our partnership and hopefully putting it into formal IAA as well. We have a number of national universities and colleges of medicine that we provide fellowship, residency, and clinical rotations. One example is our partnership with Mass General and the Rosebud Indian Hospital. And talking with Dr. Vesti earlier, collaborations with the UCSF HEAL program, and then University of Washington and Pine Ridge. I appreciate identifying and speaking to those as well. But it's really a very small trickle in a large system of care. We very much like to build upon that. There are opportunities that can be built throughout our system of care, including right here in Arizona. And I'm sure we can talk to the urban program in Nebraska and see if they have an interest as well. I wanted to do just a little bit deeper dive into the VA relationship because there's been a lot of activity in this area. We're working together again to provide services to veterans closer to home. American Indian, Alaska Natives serve at a higher proportion than any other population group in the military, and many of them return back to their rural reservation locations, and they don't get the care and treatment that they need. So we're working with the VA to ensure that they are enrolled in their benefits and that they're receiving care and treatment close to home. In December of 2012, we signed an initial reimbursement agreement so that VA reimburses the IHS for any veterans that we provide care to in any of our facilities. And we just renewed the umbrella MOU that we've had in place in 2021. That new agreement required that we come up with goals and objectives on an annual basis, and that we do it in partnership with the tribes and the urban Indian organizations that we serve. So there was a formal consultation and formal what we call urban confer conducted, and these are the top 4 goals that were identified that the tribes and urbans would like to see us working on together as an agency, bringing to bear all the resources of both entities. That also resulted in these objectives. These fall under each of those 4 goal areas. So a real focus on coordination of care and enrolling patients into their benefit systems and taking advantage of the resources that Congress allocates to each entity. The White House Council on Native American Affairs recently kicked off an initiative. They identified homelessness as an important social determinant of health for Native veterans. And IHS, in partnership with the VA, Housing and Urban Development, and our sister agencies in the Department of Health and Human Services, had developed an initiative to support education and access, mainly to the services that VA has to offer for homeless veterans. This initial work is going to focus on 5 specific cities across the country. And fortunately for us, Phoenix is right there. We do have the 3rd largest urban Indian population in the country, behind only Los Angeles and New York City. So we've got a significant population of Native veterans here, and are excited to be included in this. In addition to the federal entities of the Phoenix VA Medical Center and the Phoenix Indian Medical Center, we've got a couple of urban Indian organizations there with Native Health, who provides housing and behavioral health services, and Native American Connections. Maybe I got those 2 mixed. Native American Connections is housing and behavioral health. Native Health is more ambulatory health center, similar to a community health center that you would see. So the future of IHS, I'd just like to end here with this statement: to continue to carry out the federal government's commitment to promote healthy American Indian and Alaska Native people. What our goal is over time for the tribes to be running the entire system, and the IHS is providing contract oversight, support where needed, and the sovereign tribes are providing the healthcare that they know that their communities best. They know what the needs are locally. So it'll be tribally driven and tribally operated. I want to thank everybody for your time today. Definitely want to leave lots of time for questions. IHS is a ready and willing partner on any endeavor that will help to expand services for American Indian and Alaska Native people and reduce all of the healthcare disparities that we mentioned here today. Just a few special thank yous as the fire goes by. I want to thank Dr. Ron Johnson for spending a little time with me last week. We had a short phone call to discuss today's presentation. Dr. Donna Polk from the Nebraska Urban Coalition for her thoughts and recommendations. Jessica Seaman for helping with all the logistical support and making sure to keep me on task to be here today. Thank you. And to Dr. Anethea Powell for reaching out to me initially and inviting me to come and provide today's presentation. It's great to see you again. With that, I'll close and I'm happy to answer any questions you all might have for me. Thank you.
Thank you so much, Admiral Weahkee. We are so honored to have you here today. One of the questions that already came through on the chat, and those of you that are in person, I can run the microphone to you as well. And those of you on Zoom, you can unmute yourself or just to continue to type those in the chat. But one question that already came through is, you were talking about partnerships, and as Indian patients, do they respond better to a practitioner that is of their own tribe? And if so, are there special recruitment processes that you might be doing within the tribes, maybe even K-12 area, in trying to help those students want to go into healthcare?
Yeah, great questions. I think definitely Native peoples are driven to a health system that is reflective of their community. And so I can't point to any specific research article. I'm sure that there have been some developed, but we want to see more American Indians and Alaska Natives trained in medicine, trained as nurses, dentists, etc. Some of the programs that have been developed are attempting to reach people earlier in that pipeline or pathway. Pipeline is kind of a bad word in Indian country, so we've tried to move that over to pathway with all those oil pipelines going through reservation areas. But we want to get into the high schools, the junior highs, and even the elementary schools to start to introduce kids to potential career in healthcare. There are associations like the Association of American Indian Physicians that have specific emphasis in this area. They're in fact meeting this week in San Diego, I believe. We don't have all the resources that we would like to be able to support these types of endeavors and activities. But many of the tribes have started to do things like create their own medical schools. So the Cherokee Nation is a great example of that, where they partnered with the Oklahoma State University College of Medicine, and they've developed a campus right there in Tahlequah, Oklahoma, to begin to train Native providers in reservation-based medicine. So once their needs are met there in Oklahoma, we're hopeful that there will be a trickle down effect to those outside. And we welcome any other partnership like activities for that type of programming. We are in discussions here in the Phoenix area with ASU and U of A, of course, Midwestern. Would love to further bolster our conversation with Creighton on opportunities for residency and on other pathway projects. I try to tell people, if we can dream it, we can develop a concept paper and a proposal. We can push that to our tribal constituents who can advocate on our behalf with Congress for some funding to do it. So.
Thank you so much for that. Those pathways are really important as patients like to see practitioners that look like them and have some background like them. It kind of helps, I think, with the patient care. Any questions here in house? Yep. Here we go, Dr. Bestie.
Thank you so much. Thank you, Admiral Weahkee, for that great presentation. It was very eye-opening on so many things you talked about. One of the values and things we talk about at Creighton University a lot is social justice and structural violences that are at play in our world, in our healthcare system, in our society. You mentioned many statistics that were very eye-opening. One of them I have seen for the past 20 years and it hasn't moved. And that is the appropriations of funding for IHS. And you're at $4,100 still in 2021. It's been that way for decades. And it was amazing that the appropriations bill was passed in 2023. That's great. That was really amazing. But still, you're still funded at, or IHS still funded at $4,100 a year, whereas Medicare is $15,000 a year, and the VA is over $12,000 a year. And I'm just wondering, why is it that still every year Congress has to pass that bill to give you only $4,100? Why not more? So I guess two questions. Why is it still only $4,100? What will it take to get more than that? Because I can't imagine, how do you run a healthcare system, especially in rural areas, of really good quality healthcare when you're underfunded? And if you're underfunded, how do you produce good results? It's a catch-22. You go in a circle, right? So that's one question I have. Actually, I'll stick with that question.
All right. Well,
Thank you very much.
and there's a few ways I can take it. It's probably a question best posed to Congress and Senate, our appropriators. But the tribes are doing a great job of preparing the talking points to justify and to point out this disparity. So they have created what they believe would be full funding for the Indian health system of care. And when I was in office, that number was about $37 billion. We're currently at about 7 billion. So, it's an additional 30 billion needed to reach full funding of the Indian health system of care. They've done a lot of work justifying that number and starting to walk the halls of Congress to advocate to the powers that be. There are some structural things that need to happen, I think, for the agency to be able to advance where our appropriation currently sits. It's in the Department of Interior, where the majority of health programming sits in Department of Health and Human Services or the VA. So Department of Interior doesn't receive as much funding as these other larger departments do. And so some of the conversation is, should we move IHS's appropriation out of Interior over to HHS, which it's somewhat of a historical relic that it's still tied to Interior and has never moved over. But again, these are questions for Congress, and the tribes are knowledgeable, aware, and all over it. So it's just, trying to move that ball forward back east.
Thank you.
I just wanted to make a comment as a provider in the system for my time there. I think it is very challenging. And I think that was one of the things that was hardest for me, was that constant understanding that we were funded at a lower level than others. And it was hard. But I think one of the things that Admiral Weahkee pointed out was that the providers are some of the best that you'll ever meet. And we have so many people that you would describe as missionaries. And I say we, because I still think that I started there and it's hard for me to think of not being there. But especially, there's discussions of what White River was like back in the day. And some of the providers who were there who are still now involved in the area. But just for anyone who is considering IHS, and just like he spoke about with Doctors Without Borders and all the other opportunities that are available, you really just don't have to go very far. You can go to the San Carlos Reservation. You can stay right here in Phoenix, which was my reservation for 4 years. And you will find these providers who are missionaries and who stay despite that number, and who also learn to be incredibly creative and flexible and culturally competent about providing care. One of the things that I try to teach my residents now is actually an old Peace Corps saying, which is, don't just do something, stand there. And I think that you learn a lot of this patience and flexibility and creativity working in a resource constrained environment. As much as I would like that number to raise, It also provides some benefits as a provider to learn how to provide lean healthcare, and how to work with others to deliver the highest quality product. And honestly, you will not find some of the best. You will find some of the best providers in the country at these sites doing just that every day.
Thank you, Dr. Powell, for that little plug too. Thank you. Anybody online that would like to unmute themselves? We don't have any other questions on the chat. Any others here in the house?
I'm online, Eric Osowski, retired captain, U.S. Public Health Service, Phoenix Indian Medical Center for 34 years, and a colleague of both Rear Admiral Weahkee and Dr. Powell. I want to thank you both for your wonderful presentation today and all the comments you made. And it was an honor for me to work with both of you.
Dr. Osowski, is great to see your name and hear your voice. Appreciate you joining us today, and we miss you greatly.
Well, I miss all of you too. Thank you.
I do have a question about the traveling for Indian patients. I noticed when you showed the map, you have Nashville and then all this area north and south and east and west of Nashville that are all covered just at that one site. So if you have someone that is on the East Coast or further north, how do they take care of the travel to try to get to the closest location for them? And is it covered by IHS or is it on the patient?
Yeah, so a lot of caveats to that question, but I want to start by going back to the history and the reason why Nashville area is so large. Historically, we had a lot of tribes located there, and as colonialism occurred, tribes were pushed west. Many of those tribes that used to be on the eastern seaboard are now in Oklahoma or other locations. That being said, there are some programs located throughout. Eastern Band Cherokee is a good example in North Carolina. We've got some programs up in New York, Choctaw, Mississippi, but they're very sparse and few and far between. So it's a huge geography to cover. When it comes to traveling, those patients who aren't near a IHS federal or tribal or urban program, they do need to travel. Most of the time that is out of their own pocket. The caveats that I wanted to cover are for students. If you have American Indian students who travel away from their home reservation, they're going to school, they're covered through what we call our Purchased and Referred Care Program, PRC, used to be referred to as Contract Health Services. So we will pay for them to receive care and treatment through that fund while they're a student. Emergency care also taken care of for an American Indian who may be on travel status, get into an accident. Just like any good insurance system, they have to provide notice within 72 hours and things like that. But for the most part, those types of emergency care services will be covered. And I'll just share a little bit about how some of us handle it. So I lived in Maryland for 5 years. My father was diagnosed with cancer, and some of the best cancer care in our Indian health system is right here in Phoenix with the partnership between PIMC and Mayo. So I was flying my father back and forth between Maryland and Phoenix to receive his care here at PIMC. And it was out of pocket. So yeah, just the things that we do to ensure that our people are taken care of. If we were a fully funded healthcare system, we would probably have the wraparound services available to be able to support those types of needs. But we're restricted in a lot of ways because of our funding.
And yes, I was just going to say, and it goes back to the funding again. So Dr. Brown Shirley asked a question. She says, as a Native American neurologist with BNI in Phoenix, what do you want to see from us, your local Native physicians, to further elevate the care for our own people?
Yeah, well, I think, you know, we talked a lot about partnership here, outreach. We have some existing structures in place with the facilities that are here, both federally operated, urban operated. And we're fortunate here in Phoenix to have a lot of tribal health programs between Gila River, Salt River. I think, you know, being aware that Native practitioners exist here locally and having those referral patterns set up, having those partnerships set up, gaining credentials and privileges at the facilities so that you can be present either on staff as a contract provider or even volunteer or part-time employee, intermittent employee. I think there are a lot of options. And if we're not aware that you exist, please come and let us know that you're here, because we'd love to give you a home.
Thank you for that. I think our time is up, and we really look forward to the pathways that can be forged and with our learners, but also with our current faculty and practitioners. We look forward to that. And I'm so happy for the connections we've made in order to keep those pathways going. So thank you so much for being here, Admiral.
Thank you, Jessica. It's a pleasure. Thank you all.